Today we have several great people speaking, myself excluded, but well, to be determined. I'm going to first talk with you about glioblastoma diagnosis and management. Afterwards, we have Clayton Smith, who is a radiation oncologist who's going to talk about radiation treatment in glioblastoma. And then finally, we have one of our very talented medical students who is going to talk about the research that she's been doing with our neurosurgeons on brachytherapy and oligometastatic disease. Finally, at the end of all of that, we'll have a panel discussion with all of us, plus one of our neurosurgeons, Dr. Ben Brown, to answer any questions that come up about glioblastoma or other brain tumor diagnosis and treatment. So we'll get started. I'm Caroline Goldin. I am a neuro-oncologist at Ochsner. I've worked there for almost 3 years now, and I work, very closely with our neurosurgeons and radiation oncologists to treat patients in Louisiana and along the Gulf Coast who have primary brain tumors as well as metastatic brain tumors. And today I'm going to be talking about specifically glioblastoma diagnosis and its management. These are objectives. So the main things I'll go over is current glioblastoma demographics and WHO criteria for diagnosis, how to recognize a glioblastoma on a brain MRI, and what are the current standard treatments for glioblastoma patients. Disclosures, I did have a paid advisory position with Novocure. All right, overview of glioblastoma. To talk about glioblastoma, we first should talk about central nervous system tumor facts in general. This is a graph that is showing average annual age-adjusted incidence per 100,000 different types of cancers within different age groups. And as you can see in children age 0 to 14 years, brain and other CNS tumors make up the majority of diagnosed cancers. As you get into the adolescent and young adult population, that incidence decreases and falls behind breast cancer. And then in the 40-plus year population, brain and other CNS tumors are quite more rare than other types of cancer. This is a graph that is showing the kind of breakdown of different types of CNS tumors within adults. As you can see, about 70% of tumors in adults are non-malignant. The vast majority of those being a non-malignant meningioma, and about 28% of these are malignant tumors. We're going to be talking specifically about glioblastoma, which is a malignant tumor. This is a chart that's showing all of the different types of malignant tumor, the breakdown of their incidence in adults. And as you can see, glioblastoma makes up just over 50% of the diagnosis of malignant tumors in adults. And so it's our most common, most aggressive brain tumor. Every few years, the World Health Organization gets together and comes up with new classifications for different types of brain tumors. And the big change that happened back in 2021, the last time that they met and created these guidelines, was a shift from histological only classification of tumors to more molecular-based classification of tumors. And what this means for glioblastoma in particular, which is down here in the bottom left, is that in order to be diagnosed with the glioblastoma, you have to have pretty specific either histological, so what the tumor looks like under the microscope, or molecular characteristics. And so the first big distinguisher of glioblastoma versus other gliomas is a mutation in a molecule called IDH. For glioblastoma, the IDH has to be what we call wild type, meaning it does not have a mutation. Within the IDH wild type tumors, to be a glioblastoma, you have to meet a couple of different criteria, either histologically, meaning looking under the microscope at the tumor, is there microvascular proliferation or is there necrosis on the histology? Or even in the absence of that, they can have certain molecular alterations that can kind of bump up something that looked like it was a lower grade to this glioblastoma. And those molecular changes would be a TERT promoter mutation, EGFR amplification, or what we call gain of chromosome 7, loss of 10. And those are the different ways that a person could be diagnosed with the glioblastoma. But before all of that happens, the patient has to go through several different steps in order to be given a glioblastoma diagnosis and start to undergo treatment for it. First, a patient has to present with symptoms. After that, the physician who sees them has to obtain imaging, then accurately identify that this patient has a tumor. Subsequently, they need to have appropriate neurosurgical intervention, which then gives us our pathologic diagnosis. And after that, finally, have a multidisciplinary treatment plan. Depending on where a brain tumor develops will determine kind of what types of symptoms patients have. In adults, the majority of brain tumors are going to be what we call supratentorial, meaning above the tentorium that separates the cerebellum from the cerebral hemispheres. If a tumor is in the frontal lobe versus parietal versus temporal versus occipital, can change the types of symptoms the patient may have, again, depending on that location. If the size of the tumor is large enough that it's causing increased intracranial pressure, people may present with things like headaches and nausea and vomiting. If the tumor is close to the cortex and causing irritation, patients can present with seizures. And then again, dependent on where in the brain it is, can present with focal neurologic signs, which can include confusion or memory loss, personality changes, vision problems, speech difficulties, motor weakness, or sensory changes. When a patient comes in with a new neurologic symptom, there are a lot of different etiologies that it could possibly be. Things like migraine can present with headaches, epilepsy presents with seizures, loss of consciousness could be syncope or stroke. Change in cognition could be a neurodegenerative disease, potentially even a traumatic brain injury or a psychiatric disorder. Because brain tumors are so rare in adults, it's not always the top of a physician's differential diagnosis. And so when should someone choose to image a patient that comes in with one of these symptoms? And my answer to that is really anybody who has a new neurologic symptom or a changing neurologic symptom should be imaged for evaluation. So someone who's had migraines forever and they come into the emergency department with the exact same migraine that they've had for 15 years may not need an MRI. But if they come in and say, this is a brand new type of headache that I'm having, it's getting worse, it's associated with nausea and vomiting, that would be an indication to get imaging on this patient. So you've seen a patient, you've ordered imaging. How can you tell if something on their MRI is a glioblastoma? There are several different things that we look for on an MRI that would indicate that an abnormality is a glioblastoma. When we look at the T2 signal on an MRI, there's some surrounding hyperintensity, which can represent both non-enhancing tumor as well as edema. There's contrast enhancement that we often describe as the shaggy ring enhancement. It's typically located in the cerebral hemispheres. The textbooks will tell you it looks like a bihemispheric butterfly when it's crossing over the corpus callosum, which is a connection between the two cerebral hemispheres. And then there's early glioblastoma, which breaks all of those rules, and we'll go over some examples of all of those. This is an example of an IDH wild-type glioblastoma, and it shows on the left here, this is the post-contrast imaging, how it has that kind of shaggy ring enhancement surrounding a necrotic area of the tumor. On the right side is the T2 flare, which shows the surrounding hyperintensity, which represents both non-enhancing tumor as well as vasogenic edema. This is an example of that butterfly lesion where the lesion crosses over the corpus callosum. On the left, in the back part of the corpus callosum, on the right, in the front part. The description of the butterfly, I suppose, is because it has these sort of wing-like appearances as it's spread across the corpus callosum and then spread into the cerebral hemisphere on both sides. And these are both post-contrast images. What if you have a patient where you do imaging and you're catching the early phase of glioblastoma before it's really exploded and become this large contrast-enhancing mass that most of us could pretty easily identify? These might not have as much enhancement as a glioblastoma that's a bit further along in its development. It might have only focal nodular enhancement or no enhancement at all. The T2 flare hyperintensity surrounding it may be ill-defined or very little. The location tends to be more cortical and can sometimes involve the subcortical white matter, but again, in a small area. In early glioblastoma, we often don't see necrosis or hemorrhage or swelling or edema or this kind of shaggy heterogeneous contrast enhancement. So what could that look like? There was a paper released in 2017 by a couple of radiologists who sought to create a type of classification for these early glioblastomas. And they came up with 3 different types. Type 1, they said, predominantly involved the gray matter, the cerebral cortex. and had some T2 flare hyperintensity, but no contrast enhancement. And so what you can see on the left side in picture number A, or picture letter A, is some cortical hyperintensity on this T2 weighted image. It's pretty subtle. And then next to it, B, is the contrast enhanced image, which, as you can see, does not have any contrast enhancement in that area. That patient had another MRI 7 months later, which is shown below it, and you can see how that type 1 early glioblastoma has progressed into the more typical imaging presentation of a glioblastoma. Figure 2 shows what they call a type 2 early glioblastoma, which they defined as having T2 flare hyperintensities involving the cortex and the subcortical white matter, but still without any contrast enhancement. And again, you can see in the right-sided image, when that same person had an MRI 4 months later, it's again developed into this kind of classic-looking glioblastoma. And then the final classification they had was a type 3, which you can see on the bottom right. That is one that has some T2 flare hyperintensity, as well as some contrast enhancement, with a diameter of enhancement being less than 1 centimeter. And again, you can see even just after 1 month after that type 3 early glioblastoma, it's really kind of expanded and exploded into our typical looking glioblastoma. I have seen this in my patients as well. This is an MRI from one of my patients who our radiologist correctly identified this as looking like an early glioblastoma. On the left is a T2 flare weighted image, and you can see in her left frontal lobe there's some cortical T2 flare hyperintensity. And the T1 with contrast has maybe some subtle enhancement there, but very minimal. So she had a biopsy and was diagnosed with glioblastoma and was treated appropriately after that. I also have a couple of cases of people who, in retrospect, looking at their imaging, had some signs of early glioblastoma that were initially missed. And so I think they're really good learning cases. So this is an 81-year-old man who presented with falls and some transient left-sided weakness. He had an MRI of the brain that was read as having chronic microvascular changes, which is where we can see some of these T2 hyperintensities spotty kind of throughout the brain within the white matter. And they presumed that the etiology of his symptoms was a TIA, or potentially he had had a seizure and had some postictal paralysis. But in retrospect, if you look here, you can see on the right side of his brain, which is the left side of the radiographic image, there's that subtle hyperintensity where there's a little bit of a lighter area in his temporal lobe there, which would not be classic for microvascular changes. He followed up 3 months later, outpatient with neurology, for his presumed seizure. They had an MRI brain with and without contrast for his seizure workup. And at that time, it looked like this, where you can see that same area where we saw the very subtle abnormality now has a more defined T2 flare hyperintensity as well as an enhancing nodule. He was suspected to have malignancy, but had a fairly poor functional status with a lot of other comorbidities, and he and his doctor opted for observation. They repeated his MRI 2 months later, and it looked like this. So even just in 2 months, that small nodular area of contrast enhancement had really grown. He did end up undergoing surgery, and his pathology was consistent with glioblastoma, and he's now being appropriately treated for that. Second case for early glioblastoma that was initially missed or misdiagnosed. A 60-year-old man came to the emergency room with a new onset seizure versus syncope. He had a history of alcoholic cirrhosis, and he was in rapid ventricular rate with atrial fibrillation, and his systolic blood pressure was in the 200s. He was requiring intubation for airway protection. All of these kind of comorbidities, the way that he presents, sounds very cardiac. Could this be a stroke? So these are sort of the things that emergency room physicians are thinking when a patient like this walks in the door. His MRI looked like this, where on the left you can see, again, this very subtle kind of T2 flare hyperintensity on the left side of his brain, which again is the right side of the radiographic image. On the right side, he has his contrast enhanced study where you can see that little area of contrast enhancement. This was thought to represent acute stroke, but they still recommended that he repeat his imaging in 4 to 6 weeks, which at the time it looked like this. So even in the span of 4 to 6 weeks, that small nodule, again, got much bigger, looks much more like our classic glioblastoma. He again underwent surgery and had pathology consistent with glioblastoma and is now being treated appropriately. Okay, so you've now correctly identified a tumor and you think it's a glioblastoma. So what do you do next? The first appropriate intervention is a surgical one, and that is to not only get pathologic diagnosis of the tumor, but also the standard care for gliomas is an upfront maximum safe resection. Sometimes neurosurgeons will aim to biopsy initially if they're not sure exactly what the diagnosis is. But because maximum safe resection is the standard upfront treatment for gliomas, it's appropriate for surgeons to ask for intraoperative pathology and have the potential to transition to a resection. After surgery, patients have multidisciplinary treatment for glioblastoma, which includes continuing to follow up with their neurosurgeon for a postoperative visit and seeing radiation oncology, and you will get a much more in-depth explanation of that after me. And they'll see neuro-oncology as well. This is a screenshot of the NCCN guidelines for glioblastoma. It's a very wordy slide that essentially you can boil down to every patient with a glioblastoma who is able to tolerate treatment should have surgery, radiation, and chemotherapy with temozolomide. But where does this come from? So these recommendations come from a 2005 study that looked at the standard of care at the time, which was radiation alone, adding temozolomide both during radiotherapy as well as afterwards for glioblastoma. This is a schematic of what that protocol looked like. On the left side, you have the radiotherapy arm, where for 6 weeks, patients are getting 2 gray of radiation per day, 5 days per week, and they are also getting 75 milligrams per meter squared of body surface area per day of temozolomide. After that, they have a month-long break with no radiation or chemotherapy, followed by 6 cycles of temozolomide alone at an increased dose for 5 days in a row every 28 days. And what this showed was the addition of temozolomide to radiotherapy in this manner increased both progression-free survival as well as overall survival. And so that is what has kind of shaped our current standard of treatment for glioblastoma. From 2005 to around 2017, we had no studies that showed any improvement in glioblastoma treatment until this trial, where it looked at the addition of tumor treating fields to maintenance temozolomide versus that standard therapy alone that we just discussed for survival in patients with glioblastoma. And what this study showed was that the addition of tumor treating fields increased both progression-free survival as well as overall survival. Tumor treating fields are a device that's worn on the head. It creates alternating electrical fields, which aims to disrupt mitotic activity within tumors. So the data on this, I think, was the most exciting thing that we had since 2005. Again, it showed that the progression-free survival was increased by about 3 months between the groups. Overall survival was increased by about 5 months between the groups. But what I think is the most striking is the 5-year survival data, where with temozolomide alone, in the kind of combination therapy with radiation, the percentage of patients with glioblastoma who were alive at 5 years was about 5%, whereas with the addition of tumor treating fields, the percentage of patients who were alive at 5 years was 13%, so more than double that long-term survivor rate for glioblastomas. All right, options at recurrence. Glioblastoma, unfortunately, is a really aggressive tumor, and we never say that we can cure these tumors, even with all of the treatments that I just discussed. Glioblastoma inevitably comes back, and what we do at recurrence depends on when the tumor comes back, where it comes back, and how well the patient's doing. Unlike for initial glioblastoma treatment, there's no standard of care. So we make the best decisions that we can with the options that we have available. One option would be re-resection. If this is not followed by additional therapy, there's no survival benefit, but if it's a large tumor, could have some symptomatic benefit for the patient. Reirradiation can be beneficial in patients who have good performance status, who have a smaller tumor volume, and who have had at least 6 months since their initial radiation. There are some second-line chemotherapies that I'll talk about. There's no standard again, and so we, again, try to pick kind of what's best for the patient in the situation. Tumor treating fields are also an option at recurrence, and then, of course, clinical trials. So second-line chemotherapy options. What we most often use and that has the most data behind it currently is another oral chemotherapy called lomustine, as well as an IV VEGF inhibitor called bevacizumab. The future of glioblastoma treatment, in my opinion, I think really rests on personalized medicine and on understanding what does each patient's tumor have that's driving their tumorigenesis, that's driving this growth, and how can we adequately target that. There's not a lot of data on this yet, but there's a lot of work going into it. Certain mutations that are more commonly seen in glioblastoma that are potentially actionable are a BRAF mutation, an NTRK mutation, and EGFR mutation. And then there are a lot of other chemotherapies that people have looked at that have kind of variable evidence on. So this is a study that looked at lomustine alone, bevacizumab alone, and the combination of the two in recurrent glioblastoma and how that affected progression-free and overall survival. These are the curves for that. By kind of just looking at the curves, you can see that the people who received bevacizumab alone or lomustine alone did about the same in terms of overall and progression-free survival. People who had a combination of bevacizumab and lomustine did a bit better. However, one of the main critiques of this study that I agree with is that the majority of patients who were on the combination therapy had to have a reduction in one or both of the medications. And when the patients had to have the dose reduction, it was not nearly as efficacious. I'll talk briefly about some kind of early targeted therapies. One mutation that we look at is the BRAF mutation. This is a lot more common in low-grade tumors and in pediatric tumors, but we do sometimes see this in adult glioblastoma. We have the option to target it with treatment. We have BRAF inhibitors such as vimurafenib or dabrafenib. We have MEK inhibitors. Trametinib is a common one. We also can combine BRAF and MEK inhibition with both things like dabrafenib and trametinib together. This graph is from a study from 2023 that was retrospective. It looked at high-grade tumors, so grade 3 to 4, that had a BRAF mutation in adults. And it looked at the overall survival in patients who were not treated with targeted therapy versus patients that were. And so this suggests that there may be some difference in patients, even with high-grade gliomas who are adults, who receive this targeted therapy, that it could have a survival benefit. However, the study was very limited in that it didn't differentiate between what type of treatment patients got, as well as being a retrospective study. NTRK fusions are a newer thing that people have been talking about the last few years. They're pretty rare in gliomas. They're present in about less than 1% of cases, but they can be a tumor driver, and we have medications that can target them. Most commonly, if people have these mutations, it's an NTRK1 or NTRK3. And again, although they're rare, they can drive tumor growth, and so they can be a good target for therapy. There have been really great responses in non-CNS cancers with NTRK fusions, and so that led people to look at how can we kind of use this existing model to treat brain tumors with these fusions. And there are currently 3 FDA-approved medications for solid tumors with NTRK fusions. The most recent one is repotrectinib. That was just FDA-approved last year. I think that this one's exciting in terms of the brain tumor space because even though this was studied in metastatic lung cancer, that study did look at what was the CNS response for lung cancer metastases, and it tended to respond better than other types of NTRK inhibitors had in the past. Larotrectinib is an older NTRK inhibitor that's been studied mostly in pediatrics. I won't get into the details of the table here, but it's kind of really just to show you that larotrectinib has actually been studied in brain tumors, even though it was mostly in pediatric patients and had pretty good responses. Entrectinib is another one where there's some case reports for a few pediatric glioma patients, not a whole lot of data on entrectinib for adult glioma. The last targeted therapy that I'll mention that that has some data behind it is EGFR mutations. EGFR inhibiting medications have really transformed the lung cancer space. And so, again, it was something that we were really excited to see in the brain tumor space. Unfortunately, we have not had as much luck with trying to target that in our brain tumor patients. There is a small molecule TKI called osimertinib that theoretically should cross the blood-brain barrier. It is effective in vitro, no clinical evidence of utility yet, but we will sometimes still use that off-label in patients who have an EGFR mutation. Finally, in terms of recurrent glioblastoma, I'll talk again about tumor treating fields. Tumor treating fields were initially studied for recurrent glioblastoma before they were studied for upfront treatment that I already discussed. And this was a non-inferiority study. So they were looking at, compared to a physician's best choice chemotherapy, how does tumor treatment fields do for recurrent glioblastoma treatment? And what they found was that compared to physician's best choice chemotherapy, it did about the same, so it was not inferior. So this device, again, that creates these alternating electrical fields to try to disrupt mitosis, did just as well as a chemotherapy. Now, my kind of bone to pick with this is that tumor treating fields don't have any systemic side effects, and so we often combine them with chemotherapy, especially in the upfront setting. And so I don't know anybody who's practicing like this where if their patient has a recurrent glioblastoma, they're giving TTF only and not also chemotherapy. So I think a good next step for this could be studying this, with different chemotherapies and seeing what sort of synergistic effect we might have. That's the end of my talk. Happy to stay in touch. I have my email up here for anyone who wants it. And next we'll hear from Clayton Smith about radiation in glioblastoma. We'll have a panel discussion at the end to answer any questions. Thank you.